Right. So today I'll be talking about the role of augmented reality for precision-enabled image-guided surgery. So before I actually go into augmented reality, I just wanted to give you a little bit of a motivation for why we need image-guided therapy. So conventional surgery, the surgeon is always looking at the surface of the tissue. It becomes very difficult to identify the different structures around, especially the boundaries of the tumor, as well as the sensitive structures around. So it is important to completely excise the tumor in order to get the best possible outcome for the patient. So we've started using intra-procedural imaging in order to identify where exactly the tumor is, what the boundaries of the tumor is. This allows the surgeon to see beyond the surface. It also ensures complete resection of the tumor. So I work at the Brigham and Women's Hospital and Harvard Medical School. So at Brigham, we have a state-of-the-art operating room, which has all these imaging modalities integrated with the operating room. So you have the MR, you have the PET-CT, you have the ultrasound, you have the CT, molecular imaging, and the navigation systems. So everything is integrated with the operating room, and the information is provided to the surgeon. So I just want to highlight two surgical applications, and then I'll jump into the role of augmented reality. So the first is MR-guided parathyroidectomy. So the idea over here is these are very small adenomas of the parathyroid gland. These are posterior to the thyroid gland, and these can be as small as a grain of rice. So the surgery itself could be about 8 to 12 hours. So the idea is to use intraoperative navigation in order to localize these adenomas and avoid these sensitive nerves which control the vocal cords. It's called the recurrent laryngeal nerves. So you want to avoid these structures. So what we have done is we use intraoperative MR. So we have these MR on the rails. So with the patient in the surgical position, the MR comes in. We take an intraoperative MR of the patient. Based on this, we create these 3D models. It's almost like a navigation system. You're building a navigation system. So as the surgeon is doing the surgery, they can look at the position of the instrument. So you have a live view of what the surgeon is actually looking at. This is the instrument. That's the same instrument that the surgeon is looking at in the 3D model. That's the skin, and that's the tumor out here. This is the view from the tip of the instrument, looking down at the instrument and trying to localize the adenoma. So based on the position, the surgeon then goes ahead, makes a wider incision, and then tries to localize the adenoma itself. So we provide this image guidance to the surgery to reduce the amount of time, improve the accuracy of localizing the adenoma itself. So what is typically about an 8 to 12-hour procedure, we bring it down to about 4 hours. So we save a lot of healthcare cost in the process. The second procedure that I wanted to talk about was lung tumor resection. The idea over here is to excise just the lung and the surrounding, the lung parenchyma itself. So most of these patients are all smokers. So you want to preserve as much lung function as possible. So these are very, very small lung cancers that you can actually see on the CT images. Think of it like you have an inflated balloon. You have one particular point inside the inflated balloon, and then you collapse the balloon. And you want to find out where exactly that point goes. It becomes very difficult to localize the lung tumor, especially if you have a very small cancer, as you see in that image. So if the tumor is not localized, they take a much wider resection. So it could be either half a lung or 1/3 the lung, depending on which side they are actually doing it. So you lose a lot of lung function. The typical way of doing this is by the surgeon inserting their finger into the surgical cavity and then trying to palpate the tissue, because tumors are typically much stiffer than the surrounding parenchyma. But if you have ground glass opacity tumors, which are much less stiff, you can't feel the tumors. So they take a much wider resection. So in order to solve this problem, so the two problems that we're looking at is difficulty in localizing the lung tumors and difficulty in ensuring surgical margins. So what we do is we take, with the patient in the surgical position, we take an intraoperative image. Again, it's image-guided therapy. We find exactly where the tumor is. We place these passive fiducials very close to the tumor. These passive fiducials act as surrogate markers for the tumor. And once this is done, you can see the two passive. This is done in the inflated lung. Then the lung is collapsed. And using these two wires coming out of the lung surface, the surgeon then takes a targeted resection just around the two fiducials. So this becomes a much more targeted way of resecting out the tumor instead of taking a much wider resection or doing a lobectomy, which is removing half or 1/3 the lung. Now, as you can see, there is a lot of imaging that is actually provided to the surgeon in order to do a precise resection of the lung cavity itself. You have the diagnostic information, you have the intraprocedural information, you have all the patient-specific information. In addition, you're also looking around at the patient itself. Now the question is, how do you bring in all this information and provide it to the surgeon while they're actually doing surgery? That's where the role of mixed reality or augmented reality actually comes in. So the objective of this work was to bring in all this information and present it to the surgeon in such a way that they can customize the displays that are actually provided. So it's a concept of virtual monitors. You can customize the information that is provided to the surgeon. So what we do is we use a Oculus Rift VR device. We have custom fit this with 2 cameras in front of the Oculus Rift in order to enable mixed reality. So we have an application which brings in the preoperative images of the patient. We bring in the navigation system views that you just saw for the parathyroid surgery. It's the same navigation system views. We have the webcams which are looking at the surroundings, looking at the patient, the anesthesiologist, and all the clinicians around. You have the laparoscopic view, which you're looking at. So this is specifically targeted for laparoscopic view. You also have foot pedals and keyboards in order to customize the displays that you have. And so this is a video which actually shows the prototype. Over here, you can actually see that I'm using the laparoscope and the surgical instrument. These are the views that are provided. That's the laparoscopic view. This is the navigation system view. And you also have all the diagnostic information of images of the patient. The surgeon can look up and pull up any of the diagnostic information as they're doing the surgery. So they can look at this, they can plan out, they can find exactly where the tumor is with respect to the different structures. You can also turn off the monitors, look at the patient and the port of insertion itself. So this has been something which we have developed. Now, the thing for us is we are very careful when we provide this feedback to the surgeon. We first need to validate every one of the systems that we actually develop in the system. Because you have a patient on the table, we take that very, very seriously. So we started doing the validation of this particular mixed reality application using the Oculus Rift. So what we do is we use Ethicon validated skills trainers box. The basic idea is to do certain standard tasks. These are pegs. The idea is to transfer these pegs and then place it at specific locations. So we had 16 surgeons at Brigham try out this particular device. We compared different sorts of feedback. The instruments were tracked in real time. From these instrument trajectories, we computed the kinematic parameters. And so the idea is if a surgeon is confident about what they're doing, the typical velocity of the instruments are much larger. So by looking at these kinematic parameters, you can actually quantify whether a display is good or not. We also use the NASA Task Load Index, which is a validated questionnaire. So we have 3 specific tasks which we ask the surgeons to do. The standard peg transfer, which is taking the pegs, placing it at different points, identifying one particular radio-labeled peg, which you cannot see from the laparoscope, but you can see it from CT images. And you also have to do this task while avoiding obstructions. We systematically look at what are the differential improvement in the performance when you provide audio feedback, navigation on a screen, as well as mixed reality on the device itself. Now, I don't have time to look at all the different experiments that we've done. We just look at one particular task, which is avoiding obstructions while doing the peg transfer. You have to identify that particular peg transfer, avoid obstructions, and then place it at a particular point. And we would be comparing the results for the laparoscope plus the CT images, which is a standard of care, as well as the mixed reality devices. So the basic idea is you have these wires which are crisscrossing around. So the idea is to avoid these wires while identifying the radio label peg, picking it up and placing it at the far post. Now, this is not open. This is all done through minimally invasive ports itself. So let me just jump to the results quickly. So these are some of the results which actually show the comparison of the surgeons between the laparoscope and the mixed reality. So the blue is basically showing the laparoscope plus CT. The CT images are provided, as well as the laparoscopic images. The yellow is the performance of surgeon using the mixed reality devices. You can see that the time taken for doing the task is much lower for the mixed reality devices, as well as the path length. It's much more efficient for doing it using the mixed reality devices compared to just using the laparoscope plus the CT. And you can also see that, compared to the laparoscope plus CT, the velocities are almost equivalent. So as for the NASA Task Load Index, we look at the mental demand. The physical, the temporal demand is much higher when you don't have the mixed reality device. So it's much more difficult to do this particular task without the mixed reality device. The effort and frustration also higher for the laparoscope plus CT and significantly lower for the mixed reality device. And so now the performance looks like it is worse, but the way the NASRA task load index has been defined, the lower the number, the better is the performance. So the performance is better for the mixed reality device itself. So we've also been looking at other devices like the HoloLens, where we use this for doing both surgical planning as well as for interventions. In this particular case, this is a patient with a transplant kidney with a kidney stone. So you can actually plan the access and try to access the stone. This is a patient with temporal bone defects, which for inner ear defects. The idea is to identify the surgical approach in order to repair this defect. And this is for patients with lung cancer. And this is a tumor in the upper lobe in order to identify exactly where the tumor is and what the approach should be. We've also been looking at using the virtual reality device, the Oculus Rift, for doing diagnostic applications. So the typical way of diagnosing lung tumor, lung cancer, is by looking at longitudinal images of the patient over time and then identifying if the tumor actually becomes bigger or the solid component of the tumor actually changes in size. Now, if you need to look at all these images simultaneously, you need a very large physical space. But if you have this particular device, you can have virtual monitors, and you can look around almost 180 degrees in order to identify the lesion and make it and identify if the lesions are growing. And we did a similar sort of study where we had 5 radiologists. All the lesions were successfully identified, although the time taken was much higher. This also opens up the possibility of doing remote collaboration. So you can have an attending radiologist looking at a particular lesion. You can have the fellows at residence looking exactly at the same lesion, and the radiologist could be teaching. This could be like a good teaching tool also. And so this is obviously a team effort, and I just wanted to close up with the acknowledgement slides. Thank you.